16 or 18 up. Good evening, everyone. Can I introduce our guest speaker tonight, Mr. Abdullah Malik, who's currently working around several hospitals doing some extensive training. It's over to you, Abdullah.
All right. Thank you for the introduction. If it's okay, could I share my screen?
Yes, of course. Just find out how to do it again.
So as
there
John
you
mentioned,
go.
I'm
Yeah.
a surgical trainee in the Northeast, and my primary interest is in hepatobiliary and transplant surgery. I think my screen should be sharing now.
Yeah, that's fine. I can see it. Everyone can see it. Thumbs up. Yep.
Okay.
Very
Right.
good.
So my title is an academic clinical fellow in hepatobiliary and transplant surgery. So what that means is alongside my clinical training, I also do some research, and I'm affiliated with the Institute of Transplantation at the Freeman Hospital and with the Newcastle Fibrosis Research Group. So my talk is on the immune system, surgery, and HCC. So three very important topics and how they link together. This is my first time speaking at LIVErNORTH, so I guess firstly, there's no conflicts of interest to declare, and any views or anything expressed in this presentation doesn't necessarily represent my employing or supporting organizations, which are listed on this slide. So as this is my first time, just a bit of background. So I'm local to the Northeast. I grew up in Newcastle. I've lived on the same street my whole life. I now live 2 doors down from my parents and next door to my brother. We all live in a little cul-de-sac. So, working in Newcastle as a doctor and as a surgeon is, it's always been a dream of mine, and it's very important to me. So at the age of 18, I went to Liverpool Medical School, and then that was to study medicine. And then between my fourth and fifth year, I got involved with some research under Derek Manis here in Newcastle to do a master's in research and transplantation. Then I went back to Liverpool to complete my fifth year and worked in Glasgow for 2 years before finally coming back to the Northeast, where I belong. So my overall ambition is to become an academic HPB and transplant surgeon, and I would like to stay in Newcastle because it's, to me, it's the best place in the world. So, in terms of where I am and where I'm going, I'm currently at ST3, so third year of surgical training, and I'm on my way, hopefully, to become a consultant. Now, there's lots of hurdles and lots of steps to come to being a consultant, and there's particularly as my interests are in doing research, there's a few extra things that I need to do. So with some of those steps, one of them is to get funding for my research. So I'm planning to do a PhD, and I'm applying to various funding bodies to support 3 years of protected research time, where I can hopefully answer some important questions to do with HCC. So hopefully during my PhD, I'll be able to answer those important questions, or attempt to at least, and also keep some clinical time and do some emergency on-call and some transplant work as well alongside that, just to keep my hand in the clinical work. And then hopefully after that, once I'm a bit more established in the research world for liver cancer, to become an academic clinical lecturer, which is where I continue my surgical training and continue some research alongside that, and hopefully make it on my way as an academic surgeon in HPB and transplant. But there's other things that are important alongside this. And, for me, the two important things are family and community. So with family, I'm married, my wife's a doctor, and I need to try and support her alongside my career ambitions. And I've also got a little boy who's 1, and I don't always get the balance right, but I always need to try and make sure that I'm there for him and spending some at least quality time, if not quantity, with him and my wife. And then the community is very important to me. And I'm third generation in Newcastle, and I come from the Pakistani community. And one thing I'd like to do in the future is to get the Pakistani community more engaged in transplant and organ donation, and improve our understanding of liver diseases. Because at the minute, throughout the UK and in Newcastle as well, engagement from the Pakistani community with transplantation is sometimes a bit lower compared to other ethnicities, for lots of different reasons, most of which are cultural rather than religious. So for me, I'd like to benefit the community alongside my academic work and my clinical work as well. So moving on, my interests are in hepatocellular carcinoma. Now, as we know, it's a primary liver cancer, so it comes from the liver itself. And in the majority of cases, these patients will have cirrhosis as well, or some form of liver disease. Unfortunately, the incidence of HCC is rising in the UK and globally, and it's set to become the third commonest cause of cancer death. In 2020, there were 906,000 new cases and 830,000 deaths associated with HCC globally. And these figures, although they come from the Global Cancer Network, they're likely to be an underestimate because there will be lots of patients who have chronic liver diseases and have developed an HCC, but the HCC just hasn't been detected. So the actual numbers will be a bit higher than this, but we ultimately we don't know how many people have an undetected HCC. Now, the curative treatments for HCC are liver resection, so to remove the tumor with an operation, transplantation, which is to remove the liver and replace it, and you remove the liver disease along with the tumor, and ablation for smaller tumors. But not all patients are suitable for these treatments, unfortunately, either because the tumors are too big or because they have significant liver disease, or sometimes because the tumors, unfortunately, have spread outside of the liver. And with transplantation, while it is probably the best treatment for HCC, the listing criteria are very strict, and that's because there are lots of other indications for liver transplantation, such as alcohol-related liver disease and paracetamol overdoses and hepatitis, and these patients also need the organs. So we need to try and do it as fairly as possible. And we want patients who are being transplanted for HCC to benefit from it. Now, unfortunately, as mentioned, a lot of the patients present with advanced disease, so disease that is unsuitable for curative intent treatment or for a liver resection or for transplantation. So where does that leave us? Some of these patients are suitable for TACE, which is transarterial chemoembolization. So the artery that feeds the tumor is blocked off in the hope of starving off the tumor and reducing the tumor size through that by depleting it from its nutrients. Radioembolization is a very similar concept as well. But again, it doesn't always work in every patient, and there are some patients who it's not suitable for as well for various different reasons. So a lot of patients will receive chemotherapy, and the commonest chemotherapy agent used at the moment is sorafenib. Now, with the data that we have on sorafenib, although it's better than no treatment, what we know is that the improvement is pretty modest, unfortunately. So it can extend by about 3 months, which is something, but it just shows that we're not quite there yet in improving outcomes for patients who are not suitable for surgery yet. So there's a lot more work to be done. And some of the work that's been done is in immunotherapy. So these are new treatments which have gained a lot of traction and interest, particularly in skin cancer, such as melanoma, and also now in some types of lung cancer and blood cancers as well. So immunotherapy is gaining a lot of attention, and there's been some really exciting work that's been done in HCC for it. So when we look at the development of HCC, as I said, the majority of patients will have some form of cirrhosis. And what's thought to happen is the cirrhosis is caused by damage, which could be due to fatty liver disease, so the fat infiltrating, causing the liver to become quite stiff and hard, and then causing damage to some of the liver cells. Or it could be related to alcohol-related liver disease, or it could be related to a hepatitis infection. But essentially, there's some damage that's happening to the liver and is causing it to scar down. And as it scars, that tissue heals. And when it heals, the cells divide. And every time the cells divide, there's a risk that mutations happen. So the genetics of that cell change from what's normal to something that's abnormal. And I think a good analogy is, if you have a stack of papers, let's say you've got 20 pages that you need to hand transcribe. If you do it a couple of times, it's probably, you might have a couple of mistakes that you recognize. But if you have to do it over and over again, maybe 50 times, 60 times, the mistakes that you make might become more frequent. You might end up crossing words out, scribbling stuff, or you might end up making mistakes that you don't notice. So that's sort of what's happening here. There's lots of copies that are being made, and each time when there's a mistake, these mutations can accumulate. Now, the diagram there shows what are called the hallmarks of cancer. So these are the things that need to happen for any type of cancer to develop. And the first thing is sustaining proliferative signaling. So this is like putting the foot on the gas. So the cell is dividing and the foot is on the gas on that process. So, these signals keep going, telling the cell to divide, and it's uncontrolled. And that's what causes the growth to, or at least it's part of the cause. The second thing is evading growth suppressors. So this is cutting the brakes. So, the normal signals that tell these cells to stop dividing are not working now. This cell it's driving forward, it's accelerating, and when the signals are there to stop it, these cells are not responding to that, and they're just carrying on to divide. The cells also need to gain the ability to invade other tissues and metastasize or spread to other tissues, and enabling replicative immortality. So that's quite interesting. And what that is every time a cell divides, there are these short sequences on the genetics of that cell called telomeres, and they shorten. And each time it shortens, that's responsible for aging, and that's one of the processes by which we age. Eventually, it reaches a critical point after dividing a number of times where it can no longer shorten, and and that cell can no longer divide at that point. And that cell then becomes what we call senescent, or no longer dividing, and then it'll die, and then that'll be the end of that cell's line. But in cancer, these cells gain the ability to maintain their telomeres. So these sequences are maintained, and each time that cell divides, it doesn't shorten. And that's thought to be part of the way that they gain replicative immortality. Inducing angiogenesis is where the cancer then starts to produce blood vessels to help feed it. And resisting cell death is where the cancer then develops mechanisms to avoid the immune system, which would aim to clear the cancer. And that's one of the things that immunotherapy tries to treat, and it's one of the things that I'm interested in particular. So the immune system has a role in clearing cancer cells, but these cancer cells gain the ability to hide from the immune system. And with the liver, it's pretty interesting because the liver itself is what we call an immune privileged organ, and we would refer to it as being an immunosuppressed environment. So the immune cells that are there, they're a bit more tolerant of things that are a bit abnormal. And there's lots of theories and reasons behind that. It's thought to do because the blood that comes from the gut and goes into the liver, that has a lot of toxins in, and it wouldn't be beneficial to survival if every time your liver came across one of those toxins, it mounted a really big immune response. It would give you a fever, it would make you feel ill as if you've got a flu. And in some people, they can become quite unwell with that. So the liver tolerates these. And the other evidence that we know for liver immunosuppression is that when liver transplants happen, the amount of drugs needed to tolerate the liver, or the amount of immunosuppression needed, is substantially lower than what's needed for a kidney. And also, when the liver is transplanted alongside a kidney, the liver actually protects the kidney, and it helps prevent rejection of the kidney as well. So these mechanisms, although they're important in transplantation, they're also very important in cancer as well. So with the immunosuppression, there's lots of things that suggest there's an immune suppressed environment in the liver. And one of these is exhausted T cells. T cells are an immune cell that are responsible for killing tumor cells and infections. And when they're exhausted, it means that they've been working in overdrive and now they're just tired and they just can't do no more. And there are lots of different things that suggest the T cells are exhausted, but some markers that are present on the surface that suggest a T cell is exhausted are listed there. And one that's quite interesting is PD-1, because that's really relevant to some of the immunotherapies that we're using as treatment now. And when we look at HCC as well, there's different immune subtypes. And these different immune subtypes, what that means is that there's different immune cells in different people, and tumors in between patients can be quite different. And these are all associated with slightly different outcomes. Now, we've got what's known as an immune active outcome, as an immune active HCC, which is where there are immune cells in the tumor and they're active, they're fighting the cancer. These ones have the best prognosis because your immune system is detecting them and it's trying to fight them. It might not be fighting them effectively, but it is doing something. There's immune exhausted, which has a slightly worse prognosis than immune active. So that's, as I said, the T cells are very tired, but they're there, they're in the tumor, they're just not working as effectively as we would want. And then there's immune excluded. So that's where there are very, very few T cells in the tumor, and they're not really mounting a response against it. And these ones have the worst prognosis. So one of the things that we would like to find out is why different patients have different immune subtypes. And also, is there a way that we can convert someone from an immune excluded or immune exhausted tumor into an immune active one to try and improve their outcome? So immunotherapy aims to switch on the immune system. So one immunotherapy agent is atezolizumab, which is an immune checkpoint inhibitor. So remember that molecule I said was quite interesting in the previous slide, PD-1. So PD-1 on top of when it's on that cell surface, it's telling that T cell, right, you need to stop killing. You need to just you just need to take a break. You need to stop. And that's called an immune checkpoint. Atezolizumab is a drug which inhibits that. It counteracts that molecule and it allows the T cell to become active against the cancer. Other immunotherapies are things like T cell therapies, which are where T cells are taken outside of the body, repurposed and injected into someone, and they target the cancer directly. And there's also oncolytic viruses, which are viruses that have been repurposed and they've been made to not have a bad effect or make someone ill in the way that a normal virus would, but where they carry the effect to target the tumor and to make it seem like the tumor is an infection so that the immune system clears that infection, so it attacks the tumor. And that's quite an interesting therapy. We're not quite there with widespread treatment of patients yet, because we need to find out what the right doses are, what the effects are, and we need to really optimize that. But it is a very interesting concept and it's being studied quite extensively at the minute. Now, as I said, immunotherapy is gaining a lot of traction now, and in HCC, this trial was very important. And what it showed was that patients who are treated with immunotherapy, so atezolizumab and bevacizumab, they have better survival and better progression-free survival. So that's survival without the tumor increasing in size compared to sorafenib, which is the other chemotherapy agent. And we can see on that survival curve that there is a gap between them, and the survival does look better in atezolizumab plus bevacizumab. But when we look at the figures, the difference is 6.8 months versus 4.3 months. So it's quite a modest improvement. And alongside that, unfortunately, only about 30% of people will demonstrate a complete response to atezolizumab and bevacizumab, and we don't quite know why. We also know that patients with fatty liver disease don't necessarily respond as well to these immunotherapies as we would want. So these are all questions that we need to try and answer in the research world. So the problem is that only a minority, around about 30% of patients will respond to immunotherapy. The majority of patients who have advanced disease are still not curable, unfortunately. These patients can be treated with chemotherapy to try and improve their quality of life and give them a bit longer, but they still have the tumor, and that will still affect them. And with resection and transplantation, the recurrence rates are 70% and 20% respectively. So in particular with transplant, if someone gets a recurrence of their HCC after, there are very limited treatment options because the cancer comes back very aggressively because they're on drugs to suppress the immune system and prevent rejection of the liver. With patients who have recurrence after a liver resection, there are a few more options. Sometimes you can do an ablation or you can do another liver resection. Sometimes you can even list them for a transplant. But again, we really need to try and get these numbers down. And with transplantation, it obviously, as mentioned, has implications for organ allocation as well. The listing criteria are very strict. So trying to get more people who are within the listing criteria, trying to treat people in a way so that we can downstage them such that they can either undergo a liver resection or that they can undergo transplantation. If we can reduce the size and number of their tumors so that it's within criteria, then we might be able to improve their outcome. We also need better treatments for recurrence as well, because it is unfortunately quite a common thing with HCC. And as I said, we need to try and identify who will respond to treatments, because a lot of the immunotherapies and a lot of the chemotherapies, they have side effects. And we need to make sure that if we're going to subject someone to the risk of a side effect, that they are going to benefit. So trying to find ways that we can identify people who will respond is really important and a priority as well. And for those who don't respond to the first line treatments, we need to try and identify treatments for them as well. So second line and third line treatments. Now, I'm sure we're all quite familiar of this story of Prometheus, who taught man about fire and then was punished by the Greek gods. How the Greek gods knew that the liver would how the Greeks knew that the liver would regenerate, I've got no idea. I mean, I think it might just be a coincidence, but it is very interesting. It's a very interesting story. So Prometheus was punished by having his liver pecked out by a bird. Then it would grow back the next day, and then it would be pecked out again as his punishment. So, so the Greeks believed that the liver would regenerate, and we know that the liver regenerates after a liver resection. So in terms of what I think part of the problem is that I think when we do liver resections on people, we have a small tumor and a big tumor, and the small tumor we might not actually know about. It might be an undetected HCC. And when we do a liver resection on these patients, if we take away that big tumor, the liver is going to regenerate. And when it regenerates, it throws out lots of chemicals and lots of proteins that are called growth signals and growth factors. And they encourage the liver to grow and hypertrophy and get bigger. And that, I think, is also affecting the tumor that might be present in the liver, that undetected tumor, and it might be promoting the growth of that tumor. And that might be why some patients get an early recurrence, or why some patients get recurrence overall after a liver resection. So, where that tumor might be a little shoot in the liver, which, the immune system may be in the process of clearing it, or it might be very slow growing. I think when we do the liver resection, because the growth factors are all released, I think that stimulates that tumor to grow, and it goes from being a shoot into a plant and then spreading, unfortunately. So my hypothesis is that liver resection promotes the growth of HCC and fatty liver disease. And this is what I'm hoping to test in my PhD and to try and find out if this is happening. So the aims of my research are to see what the impact of fatty liver disease is on the surrounding immune cells, on tumor growth and regeneration in the liver. How does fatty liver disease, does it affect regeneration? Does it make the liver that comes back, does it make it better quality, worse quality, more prone to tumors? Are the immune cells exhausted? And how is the tumor growing? Is it growing in one place? Is it spreading? Do we have multiple tumors that have now formed? That's what I'm trying to find out. How does liver resection impact tumor growth? Is liver resection and the growth factors that are released, is that causing a tumor to grow? Does it stimulate that? And what is the effect of immunotherapy before surgery? So neoadjuvant immunotherapy means treating a patient before they undergo a resection. What is the effect of that on tumor growth? And if we give someone neoadjuvant immunotherapy before a liver resection, does it affect liver regeneration? Because these immune cells that have a role in clearing cancer, they also have a very important role in tissue repair and regeneration in the liver. So it might be that if the immunotherapy has an effect on those cells, that the liver regeneration could be better, it could be worse. We don't know what the effect is. So for my PhD and for my research, what I'm planning to do is to recreate the conditions using tissue. So we have tumor cells that have been donated to us with the permission of patients through biopsies, and we have normal liver tissue, which has been donated to us from patients who have undergone liver resections with permission. And what we do is with those tumor cells, we make spheroids, which are little balls of tumor. And with the liver tissue that's been donated, we make precision cut liver slices. So these are little slices of liver that contain all of those immune cells that are normally present there. And then we drop the tumor onto the liver slice. And then we hope that that tumor then sticks onto that liver slice and it engrafts. So what we call engraftment. And then through that, we can see how the tumor affects the normal liver tissue around it and how the liver tissue affects the tumor around it. And for me, because I'm interested in fatty liver disease, I would do a procedure to cause what's called fat loading. So we would put fat into this liver slice, and we can see how a fatty liver reacts to the tumor and how the tumor reacts to the fatty liver. And some of the work that my colleagues in the fibrosis group have done is shown here. So this is what the spheroid looks like when we put it under a special type of microscope. And in the middle picture there, what we can see is the purple bits are markers of blood vessels forming. So we can see that the tumor, the little spheroid there, the ball of tumor, it's caused some blood vessels to form around it, which is really interesting because it suggests that the tumor is forming. It's using those hallmarks of cancer I spoke about earlier to produce blood vessels to feed it. And on the right-hand side, we can see that actually the immune cells that are present in the liver, so those are the ones that stained green and red, they've gone towards the tumor and they're in that tissue. So we can try and see how the immune cells react in this model in the lab. And we can change the various conditions. We can we can treat it with certain things to cause fibrosis. We can treat it with certain immunotherapies to see if they work on this model, and we can use it to really try and answer some very interesting molecular level questions. So then to build on this, what I plan to do is to create a mouse model of liver resection. So this is where we have lab mice, and with those lab mice, they are injected with hepatocellular carcinoma into their liver on both sides. And then we perform a liver resection of the left-hand side, so of the bigger tumor. And then after that, we can see what happens with those growth signals. We can see, does the tumor that's left behind in the liver, the smaller tumor, does that grow? Does it get bigger? Is it more aggressive after a liver resection? We can measure different proteins that are expressed as well. Are regenerative proteins being expressed in the tumor as well? Are these proteins driving the tumor growth? We can also see what happens with the immune cells and if they're more active, less active, if they're accumulating around the tumor. And we can compare it to the tumor that's been taken away in the left side of the liver. We can compare it to that tumor and see what happens, and that can give us a real snapshot of what happens to the tumor over time. And then the next step is to then have a look at immunotherapy in this model and to see if we can get that mouse that has HCC, treat it with the immunotherapy, and see if it makes the tumor smaller. And that's what we want to achieve, because we want to find a way that we can treat HCC and we can reduce the size of the tumors so that more patients can undergo a liver resection safely and more patients can undergo a liver transplant safely. And the mouse model is what the fibrosis group we've used quite a lot for a lot of cancer research, and it does provide quite a good model. It's obviously not the same as a human, but it allows us to answer some questions we wouldn't be able to in a human, and it provides a good starting point, and through it we hope that we can answer some important questions to improve outcomes for patients with HCC. So as I said, we would do after we treat it with the immunotherapy and we see what's happened to the tumor size, we would then do a liver resection and on that mouse. And then we would try and see, is the liver regeneration that happens, is that the same as it is without immunotherapy, or is it different? The liver that comes back, is it better quality? Is it worse quality? you know, the tumor that was left behind, does that grow? Does that still grow in response to surgery? Are those growth signals the same, or are they different? What impact is immunotherapy having on patients if we treat them before a liver resection? And and through answering these questions, we're hoping that we could potentially find evidence to support the use of immunotherapy in patients with a view to reducing their tumor size to facilitate a liver resection or liver transplantation. And if we find that the opposite happens, that it doesn't work, or the liver that comes back is not good, or that it's not having the effect that we would want for on the tumor, then it's still answered a very important question. It means we have more work to do, we have more things that we need to develop, and we need to perhaps take a different approach when it comes to trying to downsize tumors before surgery. So the questions I'm hoping to answer are what is the effect of steatosis? What's the effect of fatty liver on liver resection, on the tumor, on a liver regeneration, and on immunotherapy? I want to find out what the effect of liver resection is on the tumor itself, and also how it affects how the growth factors that are produced in response to liver resection, how that impacts tumor growth and tumor behavior. Does a liver resection make the immune cells more active in a tumor? It could do, because a liver resection in general, any type of surgery, it induces an immune response. That's a normal part of the healing process. But is that healing process, is that going to drive the tumor, or is it going to clear the tumor? We don't know, but that's an important question as well. And I want to try and find out what the effect of immunotherapy is for downstaging these patients, and what impact it has on liver regeneration and repair. As I said, is the liver that's coming back, is it good? Is it good quality? Is it poor quality? And what effect is it having on the tumor that is taken away? Has it reduced the size of that tumor or not? And the tumor that's left behind, what effect is it having on that? Has it treated it completely? Has it made the immune cells more effective against it, or has it made it more aggressive? These are questions that we don't know the answer to, but I'm hoping that through my work we can at least make a start on getting some answers and trying to improve outcomes. Now, where I hope this will lead is that I hope that we'll gain a better understanding of the relationship between fatty liver disease, immune cells, and tumor behavior. And through understanding that relationship, we can hopefully develop new treatments, and we can improve outcomes for patients with HCC and potentially other cancers, which share some common pathways. I'm hoping that we'll understand how surgery affects the tumor microenvironment, so the liver tissue around the tumor, and how it affects growth, and what it might what impact it has on healing after liver resection, on what effect it has on the regenerative process, and also to identify the benefit and potential safety of immunotherapy before surgery, so neoadjuvant immunotherapy. And the immunotherapy we'll be using in my models would be atezolizumab and bevacizumab, which are the ones that are used currently. So through the lab work, I think it's very important for surgeons to engage in lab work where possible, because I think through discoveries in the lab, that's how we improve outcomes for our patients, and that's how we make new treatments, and how we can improve our surgery by understanding the disease much better. So I think the future is that HCC and liver diseases will have a greater burden globally. Unfortunately, we have an aging population. We have a rising incidence of obesity, of fatty liver disease, a rising incidence of diabetes as well, which is likely to have an impact on how HCC behaves as well. But I think there's going to be an increasing complexity of the patients that we manage. There's going to be lots of different treatment pathways, different ways that they can be sequenced. And it's going to be, up to us as surgeons to work with our colleagues in oncology and hepatology, and radiology and pathology, as we have previously, is to continue working with them to try and find the best sequence of treatments for patients, and to make sure that we're matching the right treatment to the right patient. And I think with immunotherapy, there's still a long way to understand the best type of immunotherapy and how it works and what impact it has. But I think in the future, we'll see a wider role for downstaging patients with immunotherapy, particularly for liver resection. Transplantation, because patients are put on immunosuppression afterwards, there's still a bit more we need to try and understand about that, because the immunotherapy could affect how a liver graft is accepted by a recipient. But I think, as our understanding increases, I think we will be using these treatments far more commonly in the future to try and reduce the tumor size, so that more patients can undergo a liver resection or a liver transplant. In terms of my acknowledgements, Professor Steve White and Professor Derek Mann are both my supervisors in the lab, and are mentoring me, and they've been supporting me in my funding applications. Dr. Jack Leslie is a lecturer in cancer immunology in the fibrosis group, and he's been also supporting my applications and has given lots of advice. And Eric is a PhD student in the fibrosis group, and he kindly provided me with some data and has supported me in the lab with some of the work that I've been doing as well. And those are my acknowledgements, and I'm very grateful to them. Thank you for listening. I've had a very nice time speaking about something that I'm very passionate about, and something that's really, really important to me. And I'm happy to take any questions from the audience.
Excellent. If you'd like to put your hand up, if you'd like to ask a question, I'll try and put some kind of order into it. Any questions? I've got a couple myself. Okay, then, Alf, you'll have to unmute.
Okay.
Alf's a biochemist, by the way, Abdullah.
Actually, I'm fascinated by the work that you intend doing in the lab. This idea of the slices of liver and then dropping on the actual tumor. How do you get the correct environment though for those cells to grow so you can carry out the appropriate research?
Yeah, so it's a really good question. So there's a few different things we do. So with Professor Fiona Oakley, she's done a lot of work on optimizing this model, and there's a particular way that we incubate them. We have a special media or nutrient juice that we give the tissue to grow, and then we supplement that with various growth factors and proteins that we know are present in the normal liver tissue and stimulate growth. And what's really interesting about this model is that like you said, there are the liver has particular conditions where the tumor will grow. There's also particular conditions where tumors won't grow, but they are still present. Sometimes there's lots of theories around how HCC tumors have very low oxygen, that they're hypoxic. So we can put them in low oxygen environments as well to try and simulate that. So it is a really good model. We can do lots of different environments for it. So, yeah, we add a lot of the different growth factors that are normally present to try and make the correct environment.
And what about temperature?
Yeah, so temperature, we keep it in an incubator, which is temperature controlled to normal human body temperature. Sometimes we can it's also controlled to maintain oxygen at 21%, but we can put it in another incubator which has a much lower oxygen tension at 5%. So 21% is atmospheric, so it's what we breathe in, but we can put it in low oxygen environments as well.
Fascinating. Thank you. Yeah.
Okay, Yvonne, there you go.
Can you hear me okay, John?
Yes, I can hear you, Yvonne. Yeah.
Abdullah, it's lovely to see such passion coming from a local lad who's really keen to serve the community. And thanks ever so much for what what you're doing and what you're saying tonight. For me, I've got to say there's a bit of an elephant in the room for me here simply because of the terminology of the fatty liver. Because I've recently been involved with Prof. Anstey's, the change of the name from non-alcoholic fatty liver disease to MASLD. And you're still using fatty liver. Now, my understanding of the liver, and believe you me, I'm far from medical, but my understanding would be that a liver becomes fatty in a later stage, whether it's alcohol related or whether it's metabolic related or whatever. But what you were talking about there is you're interested in what I see as MASLD patients and HCCs, which are coming from your NAFLD, MASLD patients. Am I right in thinking that?
Yeah, so you quite rightly pulled me up on using the terminology fatty liver, and unfortunately a lot of us are still using it. So it is very appropriate to make sure that we are corrected. And to be honest, I heard it a couple of weeks ago on when I was at work. So going forward, I will also make sure that we're using the correct terminology, because for various different reasons we're not supposed to use that. Partly because it doesn't reflect the actual disease process as well. And yeah, you are quite right that my interest is in what's happening with MASLD, with when there is steatosis in the later stages of the disease, and how that is impacting the growth of HCC. So it is important for us to use the correct terminology, and I will make sure that happens in all future presentations. And it's part of the reason why I wanted to present at LIVErNORTH as well, because as clinicians, a lot of the time we're in our own little world, and it very quickly becomes very small. But being able to present to a support group and liver patients and to the public like this, it keeps us on the right track. And the other thing just to highlight is, with the research that I've proposed and anything like that, if there is any input on some questions, if anyone in the audience thinks, well, I know that you're doing this, but have you thought about doing it like this? That's something that we always appreciate as well, because we can get quite tunnel visioned, and it's important to make sure that we know that the world is a lot wider than how we're seeing it.
Thank you.
Or,
wonderful work anyway. Thank you.
Good for you, Yvonne. Kate, you have your hand up?
Yes, indeed. Yes, thank you for your clear presentation. I've got a question about identification of HCC and what is regarded as the gold standard for its identification.
So for diagnosis, what we would say in general, the gold standard is the gold standard is a tissue biopsy where we can look at it. But what we find is we don't always need to biopsy. A lot of the time, the way that we pick up HCC is that we know that patients have a chronic liver disease and they're undergoing an ultrasound scan regularly. And then we see that there's a small tumor or a lump on something that looks not quite right on the ultrasound scan. And then we do a CT scan of the liver. So it's a triple phase. So there's 3 points at which the injection of the dye goes in. And that gives us a really clear picture. And then, on that CT scan, there's various characteristics of how the tumor looks in HCC. And if those characteristics are met, then we would be happy to make a diagnosis of HCC on that. Sometimes if those characteristics are not met, or if one of the characteristics is met but the other two are not, then we would then try and do another type of scan, sometimes an MRI of the liver, and sometimes we would then do a biopsy as well to try and get the tissue and have a look at it.
Okay, thank you.
Okay, Kate, thanks. So I've got a couple of questions for you, Abdullah. First of all, the one obvious one: how much is it going to cost for your PhD?
So the PhD fees at Newcastle University are about £15,000. In terms of the research itself, the research is to cover my salary and then the consumables for that time. So that tends to go all together into sort of the ballpark figures of about 250 to £300,000. But that's why we apply to there are various institutions and schemes for us to do a PhD, which cover a lot of those costs. So don't worry, I'm not going to be sending
No, it's all right.
£300,000 to LIVErNORTH.
But we have helped surgeons in the past with their training. In fact, Steve White and Jeremy French. The other thing is, is anyone, to your knowledge, duplicating or collaborating in this in other universities in other parts of the world?
So in Singapore, the National University of Singapore and the Duke Cancer Centre there, they're doing a lot of work on immunotherapy. I don't think anyone is doing quite the same thing that we're looking at, but people are looking at parallel streams. So a lot of people are looking at different conditions. So, if a mouse has HCC and then the HCC is spread outside of the liver, how that's being treated and what effect immunotherapy has on that. So there's a lot of work in the area, but I don't think anyone is looking at specifically what we're proposing to investigate.
Okay, and the other question, this is from a layman's point of view, because that's what I am. You've mentioned 2 immunotherapy drugs that you're trialing. Did you look at gene therapy or any other radically widely, they're using repurposing drugs now and using, they're doing a lot of work with that now, testing currently approved drugs to be used in other, like aspirin is being used for lots of things, apart from what it was originally designed for. And, as you probably know, Sir John Byrne's been doing a lot of work on that.
Yeah, so there's been some work recently about aspirin in colorectal cancer prevention as well, which is quite interesting. So it is a big area of repurposing currently used drugs. For us, we had a look at a couple of different options, and gene therapy was one of them, but ultimately, the reason why we went with the atezolizumab and bevacizumab was because it's currently being used in patients with HCC, and we also have quite good access to it, and we know quite a lot about about the different side effects, the dosing. But there is work being done in gene therapy. There's I think particularly at the Crick Institute in London. And it's all a very exciting area in cancer research. And I think, yeah, as time goes on, we will see more of gene therapy going forward. The oncolytic viruses that I mentioned, so that they can be used in gene therapy as well. So it's very interesting. But for me, I suppose it was to try and use the strengths that we have here, and then maybe in the future after the PhD, when hopefully I'm carrying on doing some research, to then look at other avenues as well.
Excellent. Well, I've got no more questions. Well, there's a comment I don't know if you've seen the comment in the chat, and it sums it up really. It's from Fiona, who says there's no questions, but she just wanted to say what a wonderful talk. Fascinating hearing about your work, and also loved hearing that work isn't the only thing in your life. So that's wonderful. So sorry, Joan wants to say something.
Yeah, I was just going to say that if LIVErNORTH can help in any way, with opinions or indeed financial, perhaps not to the tune of 250,000, but we're here, and do approach us.
Yeah, and you can tick a PPIE box now. Definitely, you've had a good public participation in your proposals.
Well, I've really liked speaking here tonight. Everyone's been very welcoming. I like that. Everyone has had opinions. And in particular with Yvonne pointing out that we should be referring to it as MASLD, because that's very important.
No, that's
It's
right.
very important in our applications as well to make sure that the correct terminology is used.
Yeah, well, do that. But by all means, run anything past us, because we're very, very used to looking at documentation.
Yeah, no, that'd be very helpful. I'm very appreciative of the support.
Okay, well, thanks very much, Abdullah, and thank you everyone for attending. I'm going to get in touch with you soon about to have another meeting about the website. But until then, thank you so much, and Happy New Year, by the way.
Yeah,
and we'll see you all soon. Bye.
All right.
Bye, everyone. Bye.
Bye. Thank you.
you.